So the topic today is clinical assessment and diagnosis of oral cancer and oral potentially malignant disorders. Today, October 1st, has got a lot of historical significance or perspective. First is the World Senior Citizens Day. So the senior citizens or the elderly people do play a part in today's topic of discussion. They are prone to the topic what we are going to discuss today. So it's our duty to acknowledge their services to society, take care of them, and see that we prevent them from oral potentially malignant disorders and oral cancer. The second importance of today is October 1st is the birth anniversary of the legendary actor Shivaji Ganeshan. So the entertainment media or the cinema play a major role in helping we, the healthcare professionals, to fight together to treat oral cancer and potentially malignant disorders. So with this brief introduction, I go on to my presentation. This is the latest census which has been released by the IARC, which is the International Agency of Research in Cancer, which talks about the statistics or the epidemiological data of the prevalence of oral cancer. The latest census was released in 2018. So per year, there are about 354,000 cases of exclusive intraoral cancer. And it comes within the top 10 cancers in each country. But when you combine the oral cancer with the oropharyngeal cancer, the amount rises to almost 4,54,000, and out of which the global death per year is around 2,30,000 cases die because of oropharyngeal cancer. And out of this huge amount, India alone contributes to more than 1 lakh cases per year to the global statistical pool. So what do we need to do to prevent this number from increasing? And as you see in the graph, the areas marked in orange are the areas of low socio-economic countries where the incidence and prevalence of oral potentially malignant disorders and cancer is more. Entire Southeast Asia, the Indian subcontinent, India, Pakistan, Sri Lanka, Papua Guinea, Maldives, and then Africa, South America, Brazil, Uruguay, part of France, the African continents, highly prone for oral cancer. And the next bar diagram shows the age standardized incidence of oral cancer involving the lip and the oral cavity in the high-risk country. And out of statistical interest, if they ask you which country has got the highest prevalence or incidence rate of oral cancer, first is Taiwan, followed by Papua New Guinea. And if you look at India, it's somewhere middle of the graph, about 15 to 17 or 19 cases per 100,000 population is the incidence rate. This is a schematic representation taken from WHO, which shows the various sites in the oral cavity or in the oropharyngeal region which are involved with oral cancer. If there is quite a few postgraduates in this audience, I would like to introduce the concept of ICD classification or International Classification of Diseases. Instead of just saying cancer of the Is the audio clear now?
Yes, sir.
Okay. Sorry for the delay. Yeah. So, when we say cancer, as far as the cancer, when we mean cancer, as far as dentistry is concerned, we mean mouth cancer. And in mouth cancer, we mean specific oral cancer or oral squamous cell carcinoma. So to prevent an oral cancer, you need a lot of public awareness and public involvement, professional involvement. We dentists, either specialists or general dental practitioners, need to attend a lot of continuing professional development program to update ourselves on the diagnostic aids and the preventive aids, start of our large-scale preventive measures like tobacco cessation, reduction in alcohol consumption, diagnosis, and referral. So today I'm going to concentrate on this important aspect of diagnosis and referral to curtail the spread of oral potentially malignant disorders and oral cancer. And once you do a diagnosis and referral, the care and the aftercare management you are going to initiate. With a lot of advances in science and technology where research is going on at a molecular level or a genetical level or the era of personalized medicine, days are not far where the exact precision whether an individual can have a malignant transformation of a cancer would be detected and the treatment initiated. So day is not far when you're going to reach that stage. But as of now, the gold standard or the most effective way of diagnosing and preventing is a chair-side clinical diagnosis, which each one of us need to know, and it's going to serve you a lifetime in your profession. This is just one slide to brush up your basics on the risk factors of oral cancer. Topping the list is tobacco. 80% of the, or 74 to 75% of a patient or persons who have oral cancer, they have a positive history of tobacco usage, either chewing or in the form of smoking. And out of which 80% of males have tobacco positive habit, and about 64% of females have a positive tobacco habit. Smoking has got an increased risk compared to
They are also using it simultaneously.
Is it okay now? Has it been rectified now?
Yes, sir.
Okay. Is it clear now?
Yes.
Okay. So again, sorry for the interruption. So if you look at the risk factors of oral cancer, tobacco tops the list with 75% of the patients with oral cancer having a positive history of tobacco usage in some form, either smoking or in the form of smokeless tobacco. Next is alcohol. So there's a direct relation between the quantity of alcohol intake and the chances of carcinoma developing. About 1 to 2 drinks per day, the chance is about 1.5% that you're going to develop a carcinoma. With 3 to 4 drinks, it increases to about 2.5%. And more than 5 drinks per day, it's almost 5.5% of chances of carcinoma developing. So if you have a habit of tobacco with alcohol, the risk is always additive. The next risk factor is ultraviolet radiation, which is being directly implicated in the development of actinic cheilitis, where it causes an irreversible damage to the mucosa, leading to a carcinomatous changes. HPV, or a human papilloma virus, is a major cause of concern for carcinogenesis, especially in the Western world. Not much cases have been reported from the Indian literature. Maybe we have not done a study to assess the role of HPV much in the Indian subcontinent or Indian population. But Western world, yes, HPV 16 with oncoprotein E6 and E7 playing a major role in carcinogenesis. Immunosuppression, with advancing age, when there is an immune dysregulation, chances of carcinogenesis. Or immune suppressive drugs, like for a graft versus host reaction or to prevent a graft rejection, drugs which can cause immune rejection, to prevent immune rejection, can cause carcinogenesis. Or immunosuppressive cases like HIV, individuals are prone to carcinogenesis. Areca nut, exclusively confined or to our part of the globe, India and the Asian countries. Gutkha, pan masala, mawa, with tobacco and without tobacco, causing submucous fibrosis and then causing carcinogenesis. Mate is not seen in the Indian population, but it's a very, very common cause of cancer developing in Brazilian countries. It's a kind of a very hot drink got from a herb called as ilex, extremely boiling hot drink where people consume it with a metal straw. This causes an inflammatory changes in the palatal mucosa, leading to a carcinoma of the palate. Low socioeconomic status, education levels can cause an increased risk of cancer by about 2.2%. So here, friends, it is from this slide I want all of you to pay attention, especially for undergraduate students or postgraduate students who are in the initial part of their career. The 6 most important clinical steps to diagnose a potentially malignant disorder or an oral cancer. First is assessment of risk factor, extraoral examination, intraoral examination. Assessment would include history taking, so nothing can replace a proper history taking, an extraoral examination, and an intraoral examination. Next is, once you do that, you will have to record your abnormal findings. Once you do that, you go ahead with the diagnosis, and then you start the treatment or the referral. So once you have done the diagnosis, it starts with the referral and surveillance. So this is a flow chart or an algorithm of what the above 6 steps were mentioned. So you have a new patient coming, you have an emergency patient, you have a recall patient. Take a proper history, assess the symptoms and the risk factor. It could be either a positive risk factor or an absence of a risk factor. If there is an absence of a risk factor, all that you need to do is just educate the patient. If there is a positive risk factor, you will have to start with the modification or proceeding further. Then you go to a thorough extraoral examination. If there is any abnormal finding in the extraoral examination which you feel you are not competent to proceed further, best in the interest of the patient is to be referred to an appropriate specialist. Then an intraoral examination, clinical, with or without screening agents or diagnostic agents. Any abnormality, record it. If there is a suspicion of a pre-malignancy or a malignancy, you then divide them into lesions which are low suspicion, higher suspicion, and which have the highest suspicion. Then again, you use your adjunctive techniques, biopsy, and then come to a diagnosis for lesions which are dysplastic, non-dysplastic, or a well-established carcinoma. This is a form which is being supplied by the American Dentalist Association, which will be quite useful in an academic practice or in a private practice if you want to assess the risk factor for people who are prone to potentially malignant disorders and oral cancer. It first starts with a symptom history of mouth ulcers, bleeding sensation, alteration in taste. Just you'll have to tick them up. Then a detailed examination or history taking of the different tobacco products like cigars, cigarettes, pipe, alcohol history, how many drinks are consumed per day, nutritional history, whether the patient has got an interest to stop tobacco chewing or alcohol consumption, a brief history about the medical status of the patient or the immunosuppression of the patient, and then finally it gets concluded with the tobacco cessation, whether you have asked the 5 A's to the patient: ask, advise, assess, assist, and arrange. So it's mandatory for any clinician dealing with potentially malignant disorders to have this risk factor form, assessment form filled up, and then proceed to the next stage. Is it audible to everybody? I'm continuing it. Are you able to see the screen?
Yes, sir. Yes, sir.
Okay, now which slide are you seeing? Is it the extraoral examination or the risk assessment?
Extraoral, yes.
Extraoral exam.
Extraoral examination on.
Fine. So once you have done the risk, any problem, just stop me immediately. Suppose the screen is not visible or my voice is not audible, kindly stop me immediately or just give me an indication. So the extraoral examination, if you get trained in less than 2 or 3 minutes, you would be able to complete the extraoral examination. It first starts with the thyroid gland. Locate the bilobed thyroid gland in relation to the thyroid cartilage or the cricoid cartilage. The first thing you need to do is palpate the thyroid cartilage, then go down inferiorly, palpate the cricoid cartilage till the isthmus. This is your sternocleidomastoid muscle. Palpate the thyroid gland bilaterally by a slight reflection of the sternocleidomastoid muscle. Mandatory, you get a lot of information when you do a tracheal tug or a tracheal pulling. Just move the trachea bilaterally on either side. You will see or you will feel a mild grating sound which confirms a normal trachea or no pathology in the tracheal region. And then finally palpate the suprasternal notch. This is what you need to do in your extraoral palpation. Then palpate the lymph nodes. It's divided into a collar group of lymph nodes, which then drain into the descending chain of lymph nodes. The mastoid, the occipital, the parotid. So first palpate the preauricular or the parotid, then the postauricular, the occipital node, then the sternocleidomastoid muscle, palpate for the posterior triangle, the supraclavicular nodes, palpate the anterior triangle group of lymph nodes, and then finally you end with the submandibular and the submental group of lymph nodes, where you just slightly move the tissue or pull the tissue along the lower surface of the mandible and then look for enlarged or the consistency of the lymph nodes if they are enlarged. Then you go to the intraoral examination. Start with the vermilion border, the junction of the mucosa with the skin for the color, the texture, any lesions. Then reflect the lower lip for the lower labial mucosa, the labial gingiva. Palpate for the consistency of the labial mucosa for any bumps or swelling. Similarly, the upper labial mucosa, upper lips, the upper gingiva, the buccal mucosa for any growth, ulceration, the sensory duct orifice. Have a gauze or a cotton, pull the tongue, hold it firmly, look for the dorsal surface of the tongue, the lateral surface, identify the status of the foliate papilla if it is enlarged by any chance, the ventral surface of the tongue for any lesion or growth, the floor of the mouth. Then put your finger, palpate the hard palate for the texture or any painful conditions. Use a tongue depressor to depress the tongue. Look for the uvula, the tonsils, and the fascial pillars. Use a mouth mirror so that you get a better view in the posterior region. And then finally do a sweep test. Just put your finger from the right side to the left side of the tongue. The patient might gag. That's the only side effect you're going, but it's worth the examination. And then finally end your intraoral examination with a bimanual palpation on the floor of the mouth. Put your index finger of the right hand inside the oral cavity and then on the slightly proceed posterior and inferior till you reach the junction of the base of the tongue with the anterior pillar and supporting the other hand on the undersurface of the jaw. So this constitutes your intraoral examination. So once you have done the assessment form, the extraoral, the lymph node, and the intraoral, if there is an abnormal finding, record it. If there is a persistent lymphadenopathy, if you find a level 1 or a level 2 lymph node, the drainage is most likely to occur from a pathology arising from the oral structures. If it's a level 3 or a level 4 involvement, the pathology is most likely to arise from the region of the thyroid or the cricoid or the hypopharynx or the oropharynx. Look for any skin changes. Then intraoral. If there is an abnormal finding intraorally, it would be useful or a more robust manner is to grade the intraoral abnormal finding as a low degree of suspicious lesions, higher degree of suspicious lesions, and the highest degree of suspicious lesions. What they are, I will explain to you down the lane or down the slides, but at this moment I would stop introducing these three terminologies: low, higher, and highest. So coming to our part, diagnosis. Again, friends and students, nothing can replace a clinical diagnosis. 2 eyes, 2 hands, 2 ears, and a mind to think, you would hit 95% of the diagnosis right. Only the remaining 5% you need to use your other investigative techniques to confirm your diagnosis. Eyes are always your microscope, which would never fail you. There is availability of adjunctive aids, pathological aids, and recent genetic aids like ploidy studies to assess your clinical diagnosis, but nothing can replace your clinical examination. Once you do a diagnosis, if you're competent enough or if you have the adequate training, start treating the patient. But if you feel that a little bit of more expertise is required, so the only people who have trained to do this job for you is oral medicine specialist, and only oral medicine specialist. So kindly do not hesitate to transfer or refer your case to the oral medicine consultant. So let's go the clinical diagnostic points or tips for oral potentially malignant disorders. This group of disorders has got the maximum nomenclature as far as I know in dentistry. New names keep cropping very often. First, it was epithelial precursor lesion, or any lesion where there is a change which can undergo or has got the chance of undergoing a malignant transformation. Next, it was called as precancerous lesions and precancerous conditions. These two terminologies are very, very common in a viva question for both an undergraduate examination as well as in a postgraduate examination. So a precancerous lesion means a morphologically altered tissue or a cell which has definitely an increased chance or risk of turning into malignancy. Whereas precancerous conditions means a more generalized state with an increased risk of malignant transformation. Both convey the same meaning. So then why do they want to have two terminologies as precancerous lesions and precancerous conditions? So a lesion means where there is a clinically evident change or a lesion, carcinoma develops from the same site. For example, you have a white patch or a leukoplakia on a tongue or a buccal mucosa. Exactly in the white patch where there was a lesion, you will have a carcinoma. So there's a precancerous lesion. A precancerous condition is a more generalized state. For example, a submucous fibrosis. The whole oral cavity has got changes, a leathery mucosa, a vertical band, but in any one area, there will be a malignant change. So that's a precancerous condition. There are about 4 precancerous lesions: a chronic non-healing ulcer, a leukoplakia and erythroplakia, and conditions like submucous fibrosis, syphilitic glossitis, Plummer-Vinson syndrome. Then they found out that it is not necessary or mandatory that the so-called all the precancerous lesions and precancerous conditions will definitely undergo a malignant change. So not all lesions undergo it. It's only a very a small or a moderate amount of population of lesions and conditions which undergo a malignant transformation. So then they clubbed both the terminologies of precancerous lesion and precancerous conditions and brought in the new terminology OPMD, which is oral potentially malignant. That is, there is a chance that this lesion will undergo a malignant disorder or a change. So that's why it's called as a potentially malignant disorder. And it is this terminology we have been using till date very often in all our literature and communication. But a new terminology has been proposed in 2018. If there is an oral pathology audience or an oral surgery or an oral medicine audience here, I would suggest all of them to learn or go through the June 2018 issue of the O Journal, an exclusive issue dedicated to oral potentially malignant disorders. There they have come up with this new terminology, potentially pre-malignant oral epithelial lesions, PPOELS. The special issue has been edited by Professor Nicholas Nikitakis from Greece. So there they talk in detail how the different terminologies have evolved. The article by Professor Isaac van der Waal is worth reading in this issue. So these are the oral potentially malignant disorders. Leukoplakia topping the chart, erythroplakia, erythroleukoplakia, proliferative verrucous leukoplakia, oral submucous fibrosis, a smoker's palate, Lichen planus, lupus, and disc keratosis congenita, just for an academic completion's sake. Leukoplakia, again a term or the definition which has undergone a lot of changes since the last 4 decades or 5 decades. The first definition of leukoplakia started way back in 1978, given by the World Health Organization. A white patch which cannot be clinically or pathologically assigned to any other definable condition. Malmo from Sweden, Professor Tony Axel from Malmo, Sweden, who redefined it white patch attributed to any other disorder and associated only with tobacco and not any other cause. But the most and the accepted definition is given by vernacular Surya, which has been adopted by the WHO. So get this definition by heart. Predominantly a white plaque of questionable risk, having excluded other conditions or known disease that cause no risk of cancer. Latest definition assured I think somebody in the audience have unmuted their phone. Please switch it on.
Jano March on the song.
The audience, can you unmute, please? Please unmute. Yeah, thank you. So this is the definition of leukoplakia. Clinicians, remember, leukoplakia is a clinical diagnosis. Anything or a patch or a plaque which appears white. It's a diagnosis of exclusion, where you exclude the other conditions like a candidiosis or a keratosis or a chemical burn. And leukoplakia, a white patch, which is attributed to tobacco usage in some form. So by the classification of leukoplakia, you have a homogeneous and a non-homogeneous. A homogeneous leukoplakia clinically will appear as what you see on the tongue, a thin friable white patch, well demarcated, no surface changes, and the patient is usually asymptomatic. Either it would be a chance finding during examination, or the patient would report of a sudden development of a white patch. So not much of significance to undergo a malignant transformation. Whereas it is the non-homogeneous variety of leukoplakia which should be worth following up. Non-homogeneous, again, it's divided into a nodular, a verrucous, and a speckled leukoplakia, which was previously called as an erythroleukoplakia, or authors use the terms interchangeably. This is one slide I want the oral medicine clinicians to pay attention. A white patch or a white background with a sudden development of erythematous or red areas. So if you clinically, we call it as an ulcerated leukoplakia or a leukoplakia with erythematous changes. So before you go into the investigation of either a chair-side adjunctive diagnostic test or you go for a conventional biopsy, we would suggest that you do a smear for candidiosis. Most of the cases or majority of the cases,
I think we are muted you,
so majority of the cases are positive for candida in this erythematous patch. So take a swab, establish the presence of candida. 90% of the cases, it will be positive for a superadded candidal infection. Treat the patient with a topical antifungal. The erythematous patch will definitely resolve in about a couple of weeks. Then you go for your adjunctive diagnostic test or a biopsy. Because you're going to do a biopsy at this stage, the results might get altered. So look out for a white patch with an erythematous background to rule out a superadded candidal infection. This is again an erythematous leukoplakia. Here you find a sort of a nodular leukoplakia, a patch which was homogeneous. You have tiny excursions or outgrowths or nodular in appearance with a cracked appearance. Again, a typical nodular leukoplakia on the lateral aspect of the tongue, divided into compartments with a slight elevation from the mucosal surface. This is a verrucous or a verrucous kind of leukoplakia seen on the dorsum of the tongue with a cauliflower-like shape when you observe closely and multiple nodular. So these are the non-homogeneous variety of leukoplakia, which the patient needs to be followed up even though he's clinically asymptomatic. This is a danger, or it would sign or it would ring an alarming bell. And erythroleukoplakia or speckled leukoplakia. Sudden appearance of erythema with pain, discomfort, and a nodular appearance. There is a high chance that this variety of a speckled leukoplakia, out of all the homogeneous and the other non-homogeneous variety, has got the highest rate of malignant transformation. So try to start in your investigations for these to assess dysplastic changes at the earliest possible time. This is a new lesion or relatively new in literature, which is called as proliferative verrucous leukoplakia. The characteristic or the hallmark clinical presentation is appearance or eruption of white patches in multiple sites of the oral cavity. The most common or the preferred sites are the alveolar mucosa, the gingiva, and the palatal mucosa. More than one site is involved. Characteristically, it's of a non-homogeneous variety, a verrucous or a raised outgrowth, a verrucous appearance over the surface, and more of female predilection. A lot of cases have been reported even in the absence of tobacco chewing habit. There is a diagnostic criteria proposed by Professor Jose Bagan from Spain, which has 4 points to clinically diagnose a lesion to be a proliferative verrucous leukoplakia. First is multiple sites of occurrence, as I told you, gingiva, alveolar mucosa, palate, then the buccal mucosa or the tongue. Appearance of a verrucous appearance on the surface or a verrucous or a nodular outgrowth kind of thing. As you're examining new sites occurring in the lesion or previously areas which were not involved. And the final thing is that when you try to treat these lesions or excise, it occurs back at the same site with much more renewed vigor. So these 4 diagnostic criteria are mandatory to clinically label a lesion as a proliferative verrucous leukoplakia. So postgraduates, there's a viva question for you here in this. There's a new terminology which is being given to proliferative verrucous leukoplakia because when they did a systematic review or analyzed cases from multiple centers, they found that majority of the lesions had the 3 diagnostic points, but the surface appearance was not verrucous in majority of the cases. So now they have redesigned the terminology from a proliferative verrucous leukoplakia to a proliferative multifocal leukoplakia. That's the latest 2019 addition to the terminology of proliferative verrucous leukoplakia. So they ask you what is the difference between a localized leukoplakia or a proliferative verrucous leukoplakia clinically. The entire presentation is only based on clinical diagnostic tips. I will not be talking about pathology aspect at all. That the subsequent speakers in the next webinar series, I think, will be covering it. So I will confine myself to clinical examination, physical examination, and chairside investigations for all the conditions during my entire presentation. So if a question arises, clinically, how do you distinguish between a localized leukoplakia and a proliferative verrucous leukoplakia? First is demography. In a localized leukoplakia, it is more of a male predilection, whereas in a proliferative leukoplakia or a proliferative multifocal leukoplakia, it's more towards the female gender. A localized leukoplakia, in about 65 to 74 or 75% of the cases, there is a positive history of tobacco, whereas it's only about 35 to 40% or 42% association with tobacco in a proliferative verrucous leukoplakia. Distribution. A typical localized leukoplakia is at one site, whereas this is at multiple sites, commonly the gingiva, the alveolar mucosa, and the palate. Histopathology, it's more of dysplastic features in a localized leukoplakia. About 65 to 75 or 80% of dysplastic changes in a localized leukoplakia. Whereas in a PVL, it's only about 10 to 25% of dysplastic. You have more of verrucous hyperplasia, or you have a frank, well-established carcinoma or an oral squamous cell carcinoma or a carcinoma in situ when you do a HP examination. Again, it's only about 10 to 15% transformation of malignancy in a localized leukoplakia, whereas it is a 65 to 100%, an alarming rate of malignant transformation in a proliferative verrucous leukoplakia. Appearance, a homogeneous leukoplakia, as you saw in the previous clinical pictures, smooth, well localized. This is outgrowths, verrucous, or a non-homogeneous type. A localized leukoplakia, you do a medical management with chemotherapeutic or chemopreventive drugs, or do a scalpel excision or a laser excision. Whereas a PVL, when you excise it surgically, the lesion recurs again. A lot of articles would talk about these two terminologies. Major of the articles, they just use the abbreviation to describe statistics, which you should know for your, because a lot of theses comes from potentially malignant disorders and oral cancer. So for reference, when you go to the literature, these two terminologies will be used very, very frequently. What is an RMT and what is an AMT? The percentage of cases transforming to cancer for the whole follow-up period as an accumulative figure is your RMT, and your annual malignant transformation rate is your AMT, the percentage of cases that transform into cancer per year per observed cases during the follow-up period. So when you combine these two, this is the recent statistics published in 2019 by Varnakula Surya et al. From the collecting the samples or the data from the entire globe. It varies from 0.13% of leukoplakia undergoing a malignant transformation to 34.9% of leukoplakia cases undergoing malignant transformation. We should be happy that this 0.13% is from India, a center in Gujarat, whereas this 34.9% is from Belfast in UK. So the next two slides is to share our Savita Dental College research experience. This research was carried out by my professor, mentor, and my teacher, Professor Nyan Sundaram sir. This is the longest, I think, research in Indian statistical data, I think. We did a 12-year research. Sir did it, of which we were a part of the team under his leadership. We screened almost close to 1 lakh rural population in and around Chennai to look for mucosal changes associated with tobacco, alcohol, areca nut chewing. We found a peculiar pattern of carcinoma developing in smokers and in chewers. This would be a clinical tip for practitioners to look at cases in your practice. In a smoker, the lesion always starts from the commissures or the corners of the mouth, and then it proceeds posteriorly. The first change what you see is this kind of a grayish white lesion or an area occurring, what we call as pre-leukoplakia. There is a controversy, especially between examiners, or whether you can use the word pre-leukoplakia, because classical standard textbooks, including Burkitt, do not mention the term pre-leukoplakia. But yes, you are allowed to use. This again, I ask you to refer the 2018 supplementary issue of O Journal, the article by Professor Isaac van der Waal from Netherlands, where he beautifully argues that this term pre-leukoplakia is accepted scientifically and why it was coined. So this is the first change what you get in the commissures or in the corner of the mouth, a grayish white patch. Then it becomes a homogeneous white patch. Then you have areas of ulceration or erythema over the white patch. Then you have a nodular outgrowth and then a frank carcinoma developing. This is how the pattern proceeds in a smoker. Whereas if it's a chewer, as you see in the next slide, the lesion or the change is confined exclusively to the site where the person keeps the quid or the tobacco or the betel nut. The first change what you get is a sort of a wrinkling of the mucosa, what we call it as a chewer's mucosa. Then over the chewer's mucosa or the wrinkled mucosa, you get a homogeneous white patch, erythema, nodular, and then a frank carcinoma. So this is the pattern, you are getting it. Am I audible to everybody? Is the slide continuing? Can I proceed?
Yes, sir.
Dr. Vishnu? Yeah, okay, thank you. So this is the change you observe in a smoker and in a chewer, what we saw, and Sir has published this in his report. So this is an algorithm for people who wanted a step-by-step or an algorithm to determine what the risk factors for malignant transformation. You broadly divide it into patient characteristics and lesion.
Excuse me, sir.
Yeah,
We are not able to see the slide.
now has it come?
No, sir. Someone else is presenting. Priyanka Behra's slide is seen.
I think someone has clicked as present.
Oh, I'm sorry. Has it been rectified now?
Sir, no.
No. I think by mistake, Dr. Priyanka Behra is sharing her screen too. She need to stop it. And Dr. Indra is connected with another device. That device, you need to click on the pin that device so that we can see the screen.
No. Legacy spelling.
I think
The same way,
in has to stop.
in the right side column, if you could see Dr. Indra Gopi, there is one more slide presenting. Please click on that. Your other device. Maybe you have connected two devices, I guess.
Yeah, I'm checking it out. I think she has left.
Yeah, can I start?
Yes, sir. I'm so sorry.
No, absolutely no problem. Apologies from my end also for the disturbances. Yeah, is it clear now? Are you able to see the screen?
Yes, sir.
Okay. Okay. So this is an algorithm for the predictive risk factors for malignant transformation. The center blue column is the increased risk. Female compared more to males. If there is a histological presence of dysplasia, yes, more chances. Age, more than 60 years, more prone for a malignant transformation. So that's why I started with a tribute to the senior citizens. We need to focus on this group. A lesion of less than 5 years duration with dysplasia. A female, if it's a non-smoker, and a dysplastic lesion occurring in the lateral border of the tongue or the danger areas, more chances. Alcohol usage, yes. The size of the lesion, chronic use of alcohol-based mouthwashes, and a previous history of head and neck cancer with ploidy study or aneuploidy study with a co-added candidal infection in the specimen are increased risk factors for malignant transformation. So these are the clinical tips of what could be a clinical man or marker to suspect or to guess or have a prognosis of a possible malignant transformation and act fast. The site or the phenotypic appearance of the lesion. Less chances if it's a homogeneous type, but the moment you see surface changes like erythema, ulceration, or an induration or a proliferation, more chances of a malignant transformation. Site of the lesion. There are certain areas called the suicidal areas or the danger areas of the oral cavity. The ventral surface of the tongue, the lateral borders of the tongue, the floor of the mouth. More than 75 to 95% of chances of malignancy occurring if a non-homogeneous leukoplakia occurs in these anatomical sites. Size of the lesion. Classically, literature says that any lesion which is more than 200 millimeters squared has got a 5.5% more chance of undergoing a malignant transformation. But there's a new study which has come from the Netherlands group, where in their cohort, they found any lesion which is more than 4 centimeters clinically definitely undergoes a malignant transformation. This varies from site to site or region to region, but the cutoff point would be about 200 millimeters squared of size. Next would be the age of the patient. As I told you, and elderly age group are more prone. Somebody need to unmute their phone or the microphone. Yeah, thank you. So age, elderly people are more prone. The reason is an elderly individual is exposed to the habit for a longer duration, and as his age advances, there's automatically a compromise of the immune system or an immune dysregulation, which further can facilitate a carcinogenesis or make the risk factors to become or prone to undergo or induce a malignant transformation. The duration of the potentially malignant lesion and the gender, as I talked to you, females are more prone, especially if it's a proliferative verrucous leukoplakia. The next potentially malignant disorders is erythroplakia, rare when compared to leukoplakia. Again, as the definition goes, a fiery red patch which cannot be clinically or pathologically assigned as any other definable lesion. The lateral surface of the tongue, the ventral surface of the tongue are very, very common. And if it's a erythroleukoplakia, it's almost a 90 to 95% chances of a malignant transformation, especially if it occurs in the dorsal surface of the tongue, as you see in this picture. So with this leukoplakia and erythroplakia being the most junk of the potential malignant disorders, the next 2 or 3 slides, I will stop my clinical examination tips and go to the clinical adjunctive diagnostic techniques, which is available or which you can use in your common day-to-day practice, which should be an aid to substantiate your clinical diagnosis. First, I want students to know what they mean by a diagnostic adjunctive technique. The word is not diagnostic technique. So friends, it's diagnostic adjunctive techniques. So diagnostic adjunctive technique or an aid is that which is applied to a clinically identified or established abnormal lesion, which should help the clinician to assess or to confirm his clinical diagnosis and proceed further. So this is only the second step to your early clinical examination. So what does a clinical diagnostic adjunctive technique do? It improves the clinical care, especially if a technique is simple and used in a private dental practitioner or a fresh passed out graduate looks at a suspicious lesion. He uses a diagnostic text and he finds clinically he has found something abnormal. And the diagnostic technique also yields an abnormal result. So if he is competent, he can proceed fast early, or he could transfer it to an oral medicine consultant for further care. The diagnostic test should have a high performance rate. It should have a good sensitivity and a specificity. It should be easily available. It should be affordable for the practicing clinician and also for the patient to bear the cost of it. It should be used constantly in practice and not once in a blue moon. The diagnostic technique should be as non-invasive as possible and should have a high patient compliance. Good results, affordable, and for risk stratification, a diagnostic adjunctive technique should be able to segregate the patients as either a high-risk patient, where the treatment is different, and a low-risk patient where the treatment is different, and finally for patient referral. So let us see which are the adjunctive techniques which fulfill this criteria. This is again an algorithm or an adjunctive diagnostic aid triage, which will help you to choose the most appropriate adjunctive technique. Is the screen visible to everybody, this algorithm?
Yes,
sir.
Okay. So after you have your conventional visual and tactile examination, you have an array of adjunctive techniques available to triage the patient. So whichever technique you use, if it's a positive result in your adjunctive technique, then there's a higher probability that the patient has got an OPMD. Then mandatorily you subject those patients to a biopsy or a histological diagnosis, and then you get either a positive or a negative, and then you proceed. But if your adjunctive diagnostic technique gives you a negative result, which confirms with your clinical diagnosis of not to be a suspicious lesion, then there is always a lower probability of the individual having a potentially malignant disorder. And then you just need to reassure the patient or confirm them and follow up the patient with a negative result. So the first adjuvant technique is a vital tissue staining, or what you call it as a toluidine blue staining, which has got a 95% sensitivity and specificity. Till now, it's not clear what the mechanism or why this technique is used or what the exact science or the reason. The explanation what they gave is the affinity of this vital dye or the toluidine blue dye to the nuclear chromatin or the nuclear material of a carcinomatous cell or a dysplastic cells. It binds to it. So that's the reason which is given. Some people agree with it, but quite a few researchers disagree on that explanation. But whatever it is, the technique has been found to be of good use in clinical practice. You just need two solutions, a 1% of acetic acid and a 1 to 2% of a toluidine blue stain. First, if there is a clinically suspicious lesion, you isolate that area with 1%, or you applied 1% acetic acid, apply it to allow it to remain for about 10 to 20 seconds. And then the patient washes the area. Then you apply a 2% or a 1% of toluidine blue, leave it for 20 seconds. The patient rinses with water for 10 to 20 seconds. And then you do one more time application of 1% acetic acid, wash it, and then look for the lesion. So if it's a potentially malignant cell or a carcinomatous cell, then this will take up the blue staining. The intensity of the blue staining varies. Either it's a light blue, or if it's a highly dysplastic lesion, then it's a deep blue staining, which would warranty a biopsy. So what is the use of a vital tissue staining? A vital tissue staining is first to serve as a guide for the clinician to exactly where to put his scalpel or knife
I cannot see
for
the slide.
biopsy. You cannot see the slide?
No.
I think somebody else is logged in. Now is it visible?
No, sir. Someone else is sharing the screen, sir.
They're sharing their own picture.
I think somebody else is on the video. Clear now?
No, sir.
I think Dr. Frostica, they are sharing the screen, so they have to stop sharing the screen.
Hospital Patro is
Dr.
sharing the screen.
Frostica,
So we are looking into it, sir.
Is it okay now?
No.
alternatively, we can pin Dr. Indra's video, then the PowerPoint would be coming. That's a solution. Please have a look.
Now it's gone.
I see my presentation.
Yeah, it's gone.
I think, yes,
Clear now?
That's clear.
yes, sir. Yes.
Okay, yeah. So this would give you
My
an
apologies
idea.
again.
No, this would give you an idea where to place your scalpel for the biopsy instead of grouping in the dark which part of the white lesion are you going to put your scalpel. The second use of a vital staining is for the surgeon to decide on the margins of the tissue or the specimen to be resected during the surgery. And the third thing is for surveillance and long-term follow-up of these patients. Again, you require a lot of training to interpret the results. You can get a lot of false positives with a vital tissue staining. An example I give you, if it's an inflammatory lesion like an erosive lichen planus or a mucositis or a regenerating tissue, they take up the toluidine blue staining and they give you a false positive. Or you can get a false negative test also. An example would be a hyperkeratotic lesion Because of the thickness of the keratin, the dye does not penetrate much deep for the dysplastic cells to take it. So where a pathology is already or taking place, you can have a negative result clinic and you will have a false negative. So if you are still suspicious clinically and the vital staining gives you a contrary result to what you observe, repeat the procedure after 2 or 3 days, about 2 or 3 times. Then you are likely to get a more positive result. For example, the photo what you see here on the lateral border of the tongue. This was a patient with a graft versus host disease with a mucositis. It was a false positive because an inflammatory reaction takes place. This is a leukedema. Again, a false positive. The whole mucosa is stained. Whereas this is a leukoplakic patch, a wide area of distribution, Lugol's iodine stain. It exactly marks 2 or 3 areas where there is likelihood of a dysplastic change taking place, and the surgeon would just put his scalpel over here. So this is the principle and the shortcomings and the advantages and disadvantages of a vital tissue staining or a toluidine flow staining. Some people use a Lugol's iodine. I have no experience with that, but that they say that it stains the glycogen of the cell or the tissue, but hardly used by researchers or practitioners worldwide. So the second common chairside investigation is what is your Whale scope, which is your visually enhancing lesion or based on the principle of tissue autofluorescence. It's a handheld instrument which emits a violet blue light in the range of about 450 to 500 nanometer. There are specific cells or molecules in the tissue called as naturally occurring fluorophores, both in the epithelium and in the connective tissue, like your FAD molecule or your NADH molecule. So they have the principle of autofluorescence. So this enables the clinician to look at the fluorescence pattern emitted from the tissues in a dark background. Usually the screening for a Whale scope or an autofluorescence, the lights should be switched off. It should be a dark background, and then you look for the presence of the emission of the fluorescence, or if it's a dysplastic lesion, you will see an absence of or the loss of tissue fluorescence, which would be a guide. For example, you have a lesion on the palate, which proved out to be a carcinoma in situ. It was positive. Here again, you have an erythroleukoplakia, which proved out with a loss of autofluorescence, just confirmed by biopsy. Here on the palate, you have a pigmented lesion, and that again took up the stain, and there's a lot of autofluorescence. This is a melanoma. So here is where you get a false negative test. So again, this requires a lot of clinical experience by the clinician who uses this kind of a tissue autofluorescence to delineate or demarcate what is a false positive and what is a false negative. And as a practical tip, when you're examining our population, make sure that the patient's oral hygiene is to an acceptable level. Ask him to brush his teeth, use a mouthwash. So any food particle or debris or a biofilm over the mucosal surface can mask the actual presentation, especially if it's a chewer, a pan masala chewer or a gutka chewer. So those tobacco stains or the quid stains could superimpose on the mucosa and your results can get modified. So remove all those external sources or agents. So these are the commonly used clinical adjuvant aids, your vital staining and your autofluorescence. The others, just for academic surface, I have no experience in this again. Tissue reflectance, or what is called as chemiluminescence, is mainly used for the cervical neoplasia assessment, and where a white light is reflected and then you assess the change. Narrowband imaging is what the Japanese cohort are using to a great extent. Again, it is primarily used for a gastrointestinal carcinoma assessment, where you have 2 lights of different wavelengths to look at the superficial blood vessels and the deeper blood vessels and the associated mucosal changes. Very, very costly. And the Japanese, a few centers in Japan are using it. The other is your confocal microscopy, which can penetrate to a depth of 200 micrometers into the epithelium to look for changes. A lot of centers, especially in the US, use this technique of oral brush biopsy or exfoliative cytology. They say that the results are as comparable as a conventional scalpel-based biopsy, but no, it is not as comparable to the golden standard of your conventional histopathological examination. But here it's worth knowing it. It's pretty cheap to perform it. The results are certain extent acceptable, which should serve as a guide to go for a biopsy or not. So here what we do, you have a micro brush or a mini brush with spicules or with tufts on it. You just apply it on the lesion which is clinically suspicious. Give a gentle pressure till you induce a pinpoint bleeding. Then take it out, transfer the contents onto a slide. You stain it and you send it to a laboratory where they have a specialized microscope, a computer-assisted microscope, to look and assess the pattern of the cells and whether they are normal or whether they are morphologically altered cells or dysplastic cells. And the result is always given in 4 terminologies. A positive, that means that the cells are altered, dysplasia or carcinoma. You need to do a biopsy to confirm it. Atypical, chance it's a borderline. Some cells have dysplastic, or some cells are atypical, and some cells are normal or not atypical. Again, requires a biopsy. Negative, which means the cells are normal. There is no need for any further investigation. The patient can be reassured and followed up. If the report comes as inadequate, it means the sample what you have sent is not enough for the computer to scan or assess. You need to repeat your brush biopsy. So these are your adjunctive clinical chairside aids. Evidence-based clinical practice guidelines for the evaluation of potentially malignant disorders of the oral cavity. This is an excellent landmark paper by Mark Lichen, Anil Chaturvedi, Alexander Rosker. This has been published in the Journal of the American Dental Association in 2017. I would recommend all of you to mandatorily go through this article. A beautifully done systematic review. From the systematic review, clinical guidelines have been proposed and suggested. You will also get to know how to do a very nice systematic review, how to frame a question for systematic review, how to write and publish an article on systematic review. The statistical terminologies which are used in systematic review is just a 26 or a 27-page article, but it's worth a read. So the conclusion of this clinical guidelines of systematic review by Mark Lichen submitted to the American Dental Association, which is in practice in the ADA, they have given 6 recommendations on the need to use adjuvant technique. First recommendation 1 is, if a patient is got a clinical mucosa or a lesion in a mucosa, clinically asymptomatic, you are not able to come at an exclusive clinical diagnosis immediately. But you have some predisposing factors or etiological agents. You remove the etiological agents, you wait for a 2 or 3 week period. Then again, if the lesion persists or you have an iota of suspicion, then you subject the patient to a biopsy or an histopathology. They don't advocate use of clinical adjunctive techniques. The recommendation number 2 is that if the patient has got a clinically suspicious lesion of a dysplasia or a carcinoma, again, you don't do any clinical adjunctive techniques. You directly go for a biopsy. Recommendation 3 is that never use oral brush biopsy or a cytology as an adjunctive technique in the first place. A lesion is suspicious, and then to directly go for a biopsy. But if the patient is reluctant to go for a biopsy, then you can use it as a pre-screening tool, your exfoliative cytology, to demonstrate the presence of positive report or an atypical cell report, convince the patient why a biopsy has to be done. In that stage, you can use a cytology. Recommendation 4 is that if the lesion, there is no etiological factors, but you have a clinically suspicious lesion, then you can use an adjunctive technique which is cost effective to the patient. Recommendation 5 and recommendation 6 is that totally it bans the use of salivary adjunctive techniques. They say that any technique to do with saliva as an adjunctive diagnostic technique has no evidence base. It is not of any clinical or academic value to the patient or the clinician. So never recommend a salivary adjunctive diagnostic technique. But a salivary diagnostic adjunctive technique, in their conclusion 6, is that it has to be used only for an exclusive research purpose and not on a clinical purpose. Remember these 3 terms which I introduced in my first 6 steps. Categorize the lesion, intraoral lesion, on the basis of degree of suspicion as lesions with a lower, a higher, or the highest. So what are the category or the points when you call something as a lower risk lesion, something as a higher risk lesion, and something as the highest risk lesion? A lower degree of suspicion, absolutely normal extraoral examination. Intraorally, if it's persistent, a patch, a leukoplakia, less than 2 centimeters for more than 3 weeks, absolutely in soft consistency, and the tissue is non-friable. It's only optional to use an adjuvant technique, not mandatory. The tissue autofluorescence does not show any loss of reflectance. There is no binding of the vital stain dye to the mucosa. A higher degree of suspension is again a normal extraoral examination, but a leukoplakia more than 10 centimeters or 2 centimeters homogeneous, and less than 2 centimeters non-homogeneous, erythroplakia and erythroleukoplakia, the tissue is not homogeneous, it becomes more friable, and an optional finding of loss of tissue autofluorescence and a positive binding of the toluidine blue dye to the mucosa. The highest degree is almost, we are looking at a frank carcinoma, indurated growth, exophytic, associated with dysphagia, a sudden tooth mobility, all the features which would ring an alarm bell. And in this case, there is no need to go for any other adjuvant technique. It's a right royal clinical examination, and then you proceed further in managing. Just for completion or to introduce these 2 terminologies to the postgraduates in this audience, I have put this slide on dysplasia grading. Because your final confirmation to start the most appropriate treatment is to decide on the grade of dysplasia. The 3-tier grading is what is proposed by the WHO. It categorizes into a mild dysplasia where the abnormal architecture fills up to the lower 1/3 of the epithelium, and there are just 2 cytological atypical changes like an alteration in the nuclear size or shape, or alteration in the size of the cell or the shape, or nuclear pleomorphism, just 2 atypical changes. That's a mild dysplasia. Whereas if up to middle 1/3 of the epithelium is filled with architectural changes or dysplastic changes, it's moderate. If the entire epithelium, more than 2/3, is filled with dysplastic or atypical cells, then it is severe dysplasia. This is what the WHO recommends, and most of the clinicians use it. But recently, there is a 2-tier grading proposed by Omar Kojan from Australia, where he categorizes it as a low risk and a high risk. So you call it as a low risk dysplasia histologically when there is no histological evidence of dysplastic changes, or it's a normal appearing mucosa, but clinically you find some changes. It's a high risk dysplasia when you have at least 4 architectural changes and a minimum of 5 atypical or cytological changes, then you call it as a high risk. The problem comes with when you have a moderate dysplasia, whether you put it under the low risk group or a high risk group. So, but the consensus now is that the WHO allows you to use both the grading system, whichever you are comfortable with it, and then draw your conclusions on that and then report. So this is about leukoplakia and erythroplakia. The next common thing is what we see in our population, but not seen much in the Western population, is submucous fibrosis, a chronic insidious disease of the oral mucosa characterized by a pale blanched mucosa with vertical fibrotic bands in the buccal mucosa, horizontal fibrotic bands in the lower labial mucosa with progressive inability to open the mouth, protrude the tongue, and intolerance to hot, spicy food associated with juxtaepithelial inflammatory changes in the lamina propria. Never forget this definition, even in your sleep. So this is the characteristic clinical findings: a limitation of mouth opening, limitation of tongue protrusion, a blanched, pale, leathery mucosa, alteration in the uvula, a bud-shaped uvula, change in the voice. So everybody is well versed with the clinical findings of submucous fibrosis. The confusion comes here. What grading system you need to do or follow in your clinical practice to grade a submucous fibrosis? That's because you need to assess the severity of the disease, to assess the outcome to your treatment, and to assess a possible malignant transformation. A lot of people have given either an exclusive clinical grading or a histological grading. But again, the credit goes to pioneer Dr. Saman Varnakola from King's College, who in 2010 or 2007, he proposed it, combining the clinical and the histological grading. And this was approved by the oral medicine community in the World Workshop of Oral Medicine in 2010 in London. And this is being followed in most of the European centers, and this is what we follow in Savita also. A grade 1. Here you need to know something called as an OSF triad, which includes a blanched mucosa, depapillation of the tongue, and presence of burning sensation by the patient. So if these three features are present, these three clinical diagnostic points are present, you call it as OSF triad, associated with a mouth opening in the range of between or something till about 35 mm, that would fall under grade 1. Grade 2 is that you have the OSF triad and the mouth opening is between 20 to 25 mm or 2 to 3.5 35 mm or 3.5 centimeters. Grade 3 is again presence of an OSF triage, and the mouth opening is more severe, less than 20 mm. Grade 4 is divided into grade 4A, where you have an OSF triage, severe limitation of mouth opening, along with a clinically detectable coexisting oral potentially malignant disorder like a leukoplakia. Whereas grade 4 is a combination of the histological grading of dysplasia with the clinical grading. So you have the clinical features with presence of dysplasia, that becomes grade 4B. And then grade 5 is an OSMF which has turned into a frank squamous cell carcinoma. Again, there are varying reports of the rate of malignant transformation from oral submucous fibrosis. Somewhere between 4.5 to 6.7% of transformation. A submucous fibrosis turning into malignancy is more common in males than in females. And again, amongst people in the lower socioeconomic status with a poor nutrition. If somebody wants to do a research on submucous fibrosis, this would be one area of interest. Recent articles have shown an NQO1 and a C6019 gene polymorphism, which is very, very strongly indicated in submucous fibrosis. This would be mostly a PhD topic if some people wants to pursue on it. Another clinical finding or a clinical tip is that majority of the cases, a malignancy in a submucous fibrosis usually starts in the retromolar region. That's the commonest site. So one practical tip or clinical tip what I can give to the practitioners and the students here is that if you look at a grade 3 or a grade 4A submucous fibrosis, and then you look at the teeth, if the third molar is not erupted, if the third molar is erupted, but more buccoverted or placed buccovertedly, I would suggest that you go ahead and extract the tooth either yourself or with the surgeon, because a buccoverted tooth chronically irritates the mucosa, which is already fibrosed, and epithelial, which is compromised of vascularity. So it induces more traumatic change to an already injury-prone mucosa, and chances of carcinoma developing faster is there. So try and extract the buccoverted third molar. If you see in any of your advanced cases, there are chances, because we have seen quite a few cases, that the patient's mouth opening increases, and that is the area which is most erythematous also clinically. When you remove that, the trauma is removed, the epithelium heals quite satisfactorily in those areas. The patient feels much comfortable. It's a practical tip, but there is no literature for me to support this statement of mine. Next, we go to oral lichen planus, a chronic inflammatory disease of the skin and the mucosa. Researchers have tried to classify oral lichen planus in many forms, but still there is no uniform consensus on how to classify, because each classification has got its advantages and disadvantages. But by convention of a clinical, we divide it into an oral lichen planus, an oral lichenoid contact lesion, an oral lichenoid drug lesion, and an oral lichenoid lesion which occurs in patients with a chronic, with a graft versus host disease, the mucositis which occurs. So this is a typical reticular radiating white line or striae with a Wyckham striae. So a lichen planus is divided clinically into a reticular, a papular, an annular, an atrophic, an ulcerative, an erosive, a bullous, and a pigmented lichen planus. Not all lichen planus go into a malignant transformation. It's only the erosive kind of lichen planus which has got the highest rate of malignant transformation. But it's only about 1 or 1.5% of malignant transformation which occurs from an erosive variety of lichen planus. There are chances of a malignant transformation occurring in an erosive lichen planus if there is lesion at multiple sites, like an erosive desquamatus gingivitis, what you see here, an erosive and lesion on the tongue with deep papillation with coexisting lesions on the lip, then there are chances of more. But again, recent studies have told that tongue is the most common site for a malignant transformation in an erosive lichen planus. 2 points you need to remember. Look into the history of the patient. If the patient has got a smoking history, if the patient has got an alcohol history and an erosive lichen planus, act with caution or warn the patient to stop the habit, because smoking and alcohol in patients with lichen planus who have undergone a malignant transformation have shown that have proven to act as a contributing factor. Next thing is that assess the liver function test. Presence of an hepatitis C infection. In fact, there was a cohort study from Slovakia or Australia. Out of 200 cases of an erosive lichen planus, they had 60 cases of erosive lichen planus, which turned into malignancy, which had a positive history of a HCV infection. So start screening your patients with erosive lichen planus for a possible HCV infection also. This is a controversial topic or a lesion. A discoid lupus erythematosus. Lupus erythematosus is an autoimmune collagen disorder with a multi-system. If it's a systemic involvement, or if it's just an oral involvement, it's a discoid lupus erythematosus. In discoid lupal erythematosus, you have the typical lesion, the case what we saw and treated in Savita a few years back. You have a lichenoid lesion. This is the characteristic presentation of a discoid lupus erythematosus lichenoid lesion. Palate is the most common site, followed by the lips and then the buccal mucosa. You have a central area of erythema or redness surrounding white striae, which mimics a lichen planus, and the whole thing encompassed by a grayish or a telangiectasia lesion, a typical three-layered lesion which is characteristic of a DLE. You just treat it with chloroquine or systemic steroids, the lesion heals. And this is the second lesion what we treated exactly about 7-8 months back, a discoid lupus erythematosus. But these patients over a 7-year or an 8-year period have got a chance of undergoing a malignant transformation or a carcinoma occurring in the previous site of treated lesion. That's because there is an underlying pathology of immune dysregulation or autoimmune disorder which causes changes in the immune response and a possible malignancy occurring. So that's why a lichenoid-like lesion of a discoid lupus erythematosus has been included under the potentially malignant variety. Actinic cheilitis, very common amongst farmers or fishermen on exposure to sunlight. The lower lip is typically allowed or involved more in female population. You have this characteristic flaking or scales which mandatorily has to be present in the lesion. Then that breaks up with ulceration and then there is a malignant transformation. This is again one case what we saw and we published in the British Medical Journal a few years back, a carcinoma developing from an actinic cheilitis. But if it's diagnosed in an early stage, it can be very well treated with habit modification, topical fluorouracil, topical vitamin A. It can be treated very, very satisfactorily. Stomatitis, smoker's palate, again common seen amongst population in the Andhra belt who have the habit of a reverse smoking where the fiery end is inside the oral cavity. It typically starts as an enlargement of the minor salivary gland or inflammation of the minor salivary gland ductal orifice, then an area of white patch and erythema, and then a frank carcinoma occurring over the palatal mucosa. A chronic non-healing ulcer is a very common cause of malignancy occurring in our people, but not in the Western literature because of the much better oral hygiene status. So the Western literature doesn't report about a traumatic or a chronic irritation which can predispose to a chronic non-healing ulcer and then a carcinoma. So if you have a mechanical irritation like a sharp tooth or a denture, which irritates and causes an ulcer, you first call it as a traumatic ulcer. You remove the source of trauma, wait for 21 days or 3 weeks. That's a cutoff period. If it doesn't heal within 3 weeks, then you rename it from a traumatic ulcer to a chronic non-healing ulcer, which definitely warrants a biopsy. So what is the reason or trauma causing a malignant transformation? As you know, a persistent or a long-standing trauma or causes a chronic inflammation. A chronic inflammation releases inflammatory mediators like cytokine, prostaglandin, and a tumor necrosis factor, which in turn stimulates release of free radicals, which causes cellular and molecular changes, and then a carcinoma developing. So this is in brief about the clinical tips or the clinical diagnostic tips of oral potentially malignant disorders. So what is the take-home message? Always don't forget the rule. Wherever the rule is, you will have to follow it. Problem occurs only when you break the rules. So what is this acronym or the mnemonic for rule in a potentially malignant disorder? R stands for red. Any lesion which clinically appears red raises the suspicion to go for further referral and management. Any lesion which gets ulcerated adds more to the suspicion. Any lump which occurs suddenly, suspicion. Any lesion which was small initially, then expands rapidly to involve the adjacent areas, raises a suspicion for further investigation and management or referral. So we have seen with a potentially malignant disorder, then if not diagnosed early, if not treated early, it goes to cancer. So oral cancer, the commonest is oral squamous cell carcinoma. The definition is a malignant neoplasm which arises from dysplastic epithelial cells. Again, Professor Bargan's group from Spain divide oral cancer in an interesting article of theirs into an early stage cancer and an advanced stage cancer clinically. An early stage cancer is a lesion which is less than 2 centimeters with a sort of well demarcated ulcerate erythematous area with minute surface changes, moderate pain from the lesion. Anything which is more than 2 centimeters or above 4 centimeters, the ulcer changing into an exophytic growth, indurated, loss of function, referred pain to the other sides, a sudden loss or mobility of tooth, which develops suddenly as an advanced stage. So these are the clinical signs what a clinician or a practitioner need to know that the lesion what he is looking at is possibly a malignant lesion. I'll just give you 2 examples what we saw in Savita in our college in the span of 15 days in the last 2 weeks in the lockdown period. We had this patient, a female patient, who came to us in the month of March, if I'm right, before the lockdown. Then she could not come because of no transportation. She came 10 days back. What we saw in the month of March, the white patch, mildly non-homogeneous. It is not exactly a textbook picture of a homogeneous. The patch remained the same. The patient complained of severe pain radiating to the ear, and a limitation of mouth opening. These 3 points she did not have when she came to us in March, whereas when she came to us 10 days before, the lesion clinically remains the same. You will not have any suspicion of a possible malignancy in this lesion. But these 3 symptoms of the patient made us to wake up. We did a biopsy and the report came as a well-differentiated carcinoma. This is one example where you will have to give importance to the patient complaints. That the idea is don't reject any complaint of the patient. Remember, dear students, the patient is never wrong. The patient is always right in his complaint. So don't brand any patient as a psychological patient. He's just complaining. No, unless he has a problem, 99.9% of the patients report what they are feeling. So never reject any complaint or any history from the patient. So this patient proved out to be a carcinoma. This is an 84-year-old lady who has been undergoing regular dental extractions, but with comorbidities of a renal disorder and a cardiac disorder, developed burning sensation in the lower lip. That was her complaint, no other complaint. Burning sensation, and a mild swelling on the labial and the buccal, on the lingual and on the buccal gingiva. This was her complaint. Then immediately an X-ray was taken. The practitioner did not heed to the complaint. The tooth was slightly mobile, a sudden mobility of the tooth. He did not pay attention to it. He extracted the tooth. Within 48 hours, this was the picture. This was immediately the next day after extraction. Within 48 hours or 3 days, the swelling increasing in size, area of ulceration, and an exophytic or a proliferative growth on the buccal gingiva. Then when we took a panoramic X-ray, there was a whole change, what you call as a typical base and promontories appearance, an osteolysis occurring in the mandible. So this was an intraosseous lesion. Because of the possible nerve involvement, the patient complained of a burning sensation, which was not heeded by the clinician. So again, go or pay attention to the complaint of the patient. So once you have clinically examined, if it's a malignancy, the next site what you are supposed to look is the metastasis. This is a schematic representation of the metastatic picture. A line diagram showing the lymph node drainage. 1A is your submental nodes, 1B is your submandibular, 2A is the superficial, anterior and the deep nodes along the spinal accessory nerve. 2B is your posterior and your superior nodes to the spinal accessory. 3 is the lower 1/3 of the jugular vein lymph nodes. 4 is the deepest compartment. 5 is your posterior triangle and 6 is your anterior triangle compartment of lymph nodes. Postgraduates, there is no excuse for you if you do not do a TNM staging of a clinically diagnosed cancer you are seeing. Why is a TNM staging required? First is this is a universal language for communication regarding cancer. When you send for a publication or you discuss with an oncologist, medical people do it, but unfortunately it's we dentists, we do not do it. But oral medicine people, you should get into the habit of using or writing your TNM staging in your case sheet. That's to assess or determine what the treatment of the patient is going to be. Is it surgery? Is it palliation? Is it radiotherapy? Or is it chemotherapy? Once you have done the TNM, you will have to stage it to assess the prognosis or what is the treatment outcome of the patient. A T0, a stage 0 or a stage 1 has got a good prognosis, whereas a stage 3 or a stage 4 has got a very, very bad prognosis. So get into using these abbreviations in your practice of TNM staging. TX stands when the primary tumor cannot be assessed histologically. T0 is when there is no clinically evident primary tumor. This T0 was used till the 7th edition of classification by the AJCC. They are the regulatory body, the American Joint Committee on Cancer Research. From the 1st of January 2018, that's almost 3 years before now, the AJCC 8th edition classification has come into practice. My next slide is going to show all that. So in the 8th edition of AJCC classification, this T0 what was there in the 7th, but what unfortunately many of us still continue to use in our practice is no longer there. So the T0 has been removed from the AJCC 8th edition classification. TIS stands for carcinoma in situ, and MT stands for a multiple primary tumor. So if an oncologist writes an MT and you see a report, this means that multiple primary tumor or multiple lesion. Then you will have, suppose he says T3 or T4, then you will say which is T3 or T4, which lesion he means. So look at the lesion which is largest in size. So that lesion is taken for the tumor calculation or marking. Again, NX means a lymph node which cannot be assessed histologically. N0 is no clinically evident node metastasis. This term U and L is used for a nodal involvement in neck lesions. The term U stands if there is a nodal metastasis above the level of the cricoid, and L stands if there is a nodal metastasis below the level of a cricoid. RX is no residual tumor assessed. R0 is again a clinically no residual tumor. R1 is a microscopic residual tumor, and R2 is a macroscopic residual tumor. This is two terminologies which we oral medicine postgraduates and practitioners need to have it. A CTN means a clinical TNM staging, and a P means a pathological TNM staging. A clinical TNM staging will help you to assess what the treatment option is going to be, whereas a pathological TNM staging would help you to assess what the prognosis is after you have the entire resected specimen and you have a diagnosis, and the need to decide whether any adjunctive treatment like a radiotherapy or a chemotherapy has to be given followed a surgical treatment. So these are the new terminologies which have been included in the 8th classification. Extranodal extension, absent or present. A microscopic extranodal extension or a macroscopic extranodal extension. This is a recurrent tumor. And this is a sentinel node which cannot be assessed, a sentinel node which is absent, and a sentinel node which is present. So kindly add these abbreviations in your report. It will raise your standard amongst the medical community. And when you send for publication, when you use these terminologies, the reviewer or the editor gets impressed. Yes, here I'm looking at a paper which has got really stuff or quality in it. So this is the latest 2018 AJCC 8th edition classification, where they have included the depth of invasion. So depth of invasion is done on a histopathological report. How they do it is that you have a specimen, you draw a horizontal line from the most nearest available basement the epithelium which is intact or the basement membrane. From there, you draw a vertical line down, what they call it as a plumb line, P-L-U-M-B line. You draw a plumb line vertically down and see how far it goes into the area of dysplasia. So that's your DOI or your depth of invasion. Then, so accordingly, depending on the depth of invasion, you have a T1, 5 mm or more than 5 mm up to 10 mm or greater than 10 mm. Then T4 is again divided into 4A, 4B, depending on the associated structures which are involved. Then you have a modification in your lymph node, which is they included the extranodal extension, either the presence or absence of the extranodal involvement. M remains the same, presence or absence of distant metastasis. So based on this, this is the new staging from 2018, which all of us are expected to follow. A stage 0, a 1, a stage 2, 3, 4A, B, and C. So start using it in your practice from tomorrow. So this is the clinical assessment of oral cancer. Next is imaging. I am not going to put any imaging slides because subsequent speakers in this webinar series will be talking about exclusive imaging aspect, and I'm sure they're going to cover imaging in carcinoma also. So there are a wide range of imaging available to you, from a periapical radiograph to a PET scan. But as far as oral carcinoma is concerned, whether it's a soft tissue carcinoma or a bony carcinoma, the gold standard is to use either a CT or an MRI. Never subject a patient to all the imaging modalities just because it is available to you. Clinically decide which is going to give you the maximum information. All of us advise PET quite frequently nowadays. A clinical tip or a point what I want you to know is, when you're advising a PET scan, do it before you do a biopsy. Never advise a PET scan immediately after a biopsy, because it's going to give you a false positive test. Or if you're going to do it after a biopsy, wait for at least 3 to 4 weeks, let the inflammatory component subside, then you do a PET scan. Otherwise, do it before a biopsy. So the last couple of slides of my presentation. Things go out of control when there is a diagnostic delay. What do you mean by a diagnostic delay? The diagnostic delay is defined as the time lapse between the time interval of the patient when he reports to a physician or a clinician to the time a diagnosis is made and treatment is started. So it's called as the ARHAS guidelines of diagnostic delay, which we need to reduce to prevent an OPMD undergoing a malignant transformation. First is patient interval. It's quite common amongst the Indian patients. For the fear of expecting the worst, they try to delay meeting a physician. They think that with an antibiotic, with an anti-inflammatory, with an alternative form of medication, the lesion is going to subside down. So we need to educate our patients that anything or any lesion which is causing them discomfort or which is not normal, if it is present for more than 3 weeks, it's better they seek medical advice or opinion. So then the patient comes to you, he comes to a dental practitioner. He may be competent or he might have a doubt. So if he has a doubt, let him not start with an antifungal, with an antibacterial, with all topical ointments available to him, with the idea, his intention is good, that he has a hope that it's going to clear the lesion. But many a times it doesn't happen. It helps in the progress of the lesion. So try to avoid a delay in the primary care level. Then when the patient gets referred to a tertiary hospital or an exclusive oral medicine practice, try to keep the diagnostic adjuvants as minimal as possible and try to do your diagnosis as fast so that you can confirm the diagnosis and reduce the treatment time or start the treatment at the earliest. Oral cancer screening. That is any aid or any program which is applied to a general public who come for an opportunistic for opportunistic screening to assess their lesion. This would help to identify any abnormal changes in a general population. So it has got the advantage of early detection in asymptomatic persons, to detect pre-cancer change or early cancer, to distinguish between the disease and the disease-free, not only diagnostic but early referral. It reduces morbidity, mortality. It reassures patients who have a negative test result. So try to employ oral screening programs as frequently as possible in your institute or in your practice. Then it is the rule of every dentist, if they are not very clear, to go for a second opinion so that they get a much better option. The patient has got much more treatment guidelines or options to him, and always practice standard operating procedures or referral guidelines. Go to the RULE guidelines when you're dealing with this kind of a lesion. To finally conclude, mandatory to diagnose OPMDs and cancer at the earliest, which improves survival. We dentists, we oral medicine experts, we physicians play a pivotal role in community service. This requires competent training at all levels. And to conclude, whatever adjunctive aids are available to you, nothing ever and nothing will replace a conventional oral clinical examination. So thank you all for your patient hearing. Thank you.
A sincere thanks to you, sir, for the wisdom and knowledge you showered us with during your amazing lecture. Thank you for the exceptionally stimulating and informative webinar. Thank you so much, sir. Shall we proceed for the question and answer section?
Yeah, sure. Yeah.
So shall we proceed for the question and answer section?
Yeah.
So the first question is, why the rate of malignant transformation reported to be higher in females?
Okay. There's a possible explanation given to that. It's the females who return for screening or for consultation more frequently than men. Okay, because they are quite skeptical about the changes or the abnormalities. Men trying to take it slightly a little bit earlier or a little bit light until things get very advanced. And tobacco is the main cause of a malignant transformation or a potentially malignant disorder. If it's going to be a male patient, if you look at the statistics, the comorbidities, a cardiovascular disorder, or any systemic complication is more in a man than in a female. That's what statistics show. So the chance of mortality is already high. The mortality could have occurred because of the other underlying systemic causes. So the men do not turn up for screening. And the main reason is that female coming up for screening more than the men population.
So the second question is difference between grade 4A and grade 4B grading of OSMF.
Grade 4A is just OSMF with a clinically coexisting potentially malignant disorder like Leukoplakia. And grade 4B is an OSF triage with histological evidence of a dysplasia.
Thank you, sir. Next one is, does lymphoscintigraphy have any role in diagnosing N0?
Not much as far as literature says. Which would be the best for diagnose lymph node? There's nothing like a sentinel node biopsy. And a PET scan also has got a good role to detect nodal metastasis. But if the metastasis or the node involvement is less than 2 mm, again, a PET scan cannot take it up. A lymphoscintigraphy, yes, certain papers prove its efficacy, but there is no good quality RCT done to prove it. So I would suggest a sentinel node biopsy to be a good diagnostic.
Okay, sir. So the next one is, what's your suggested treatment plan for non-homogeneous leukoplakia cases with severe dysplasia?
I would go for a conventional scalpel-based excision and then with good two margins around the lesion for a good histopathological examination or a non-ablative laser excision.
So the next one is, how to differentiate clinically from homogeneous leukoplakia and plaque type oral lichen planus. And the second question is, how to differentiate it from the erosive and ulcerative lichen planus.
This term erosive and ulcerative lichen planus, I would say it's more or less same. Different authors use different terminologies: atrophic, erosive, ulcerative. The clinical picturation is going to be more or less same. Ulcerative if the margins are very, very irregular. Erosive if it's deep red accompanied with a gingival desquamation. The first part of the question, how do you distinguish between a plaque type of lichen planus and a homogeneous leukoplakia? It's quite difficult to look at it clinically. You will have to go for etiological factors in your history of a possible tobacco usage. And usually if it's a leukoplakia, it might be localized in one particular site. Whereas if it's going to be a lichen planus, chances that it's going to be, even if it's a plaque type, it's going to involve a larger area or multiple area of the mucosa.
So the next one is, as you mentioned in PET scan, the inflammatory components might show a false positive. How accurate do you think a traumatic ulcer will not show a false positive, saying that what according to you is a superior imaging modality for oral cancer?
Okay, could you just go through the question? I didn't understand the first part.
So the PET scan, in the PET scan, the inflammatory components might show a false positive. How accurate do you think a traumatic ulcer will not show a false positive?
Yes, a traumatic ulcer inflammation is going.
So the next part is saying that what according to you is a superior imaging modality for oral cancer.
Connection seems to have got lost. Is it clear now?
Yes, sir.
Yeah. So clinically, if you suspect a traumatic ulcer, you remove the source of trauma and you wait for it to heal. And if it doesn't heal, you're going to look in terms of a chronic non-healing ulcer, most likely to have a dysplastic change. You subject it to a PET scan, and if it still remains as a hot spot, you're going to get the impression that it's going to be a malignant change, because inflammation also shows a hot spot in a PET scan. Then you are doing a biopsy, but the biopsy might not show any dysplastic changes. You will have to wait and watch for the lesion to heal. So no investigative methodology or aid is 100% accurate. You have pros and cons for everything.
So what, according to you, is a superior imaging modality for oral cancer?
No imaging modality is superior, no imaging modality is inferior. All have got its advantages and disadvantages, from its ease of availability to the cost, which decides which imaging goes for which patient is able to afford or not. But again, evidence or literature in our practice, we use maximum CT or MRI. If clinically the lesion has got a bony involvement or an extension, we directly go for a CT with contrast. If it's an exclusive soft tissue, so a lesion in the tongue, we don't go for a CT, we directly go for an MRI.
So the next one is, what is a second primary tumor?
A second primary tumor is if you have a lesion, say a carcinoma of the tongue or the palate, you treat it. Within 6 months duration, you develop another similar lesion in the same site or somewhere in the immediate vicinity. That's called as a second primary tumor.
So the next one is, can we use FNAC in diagnosis of oral cancer?
Just also another clinical adjunct, but not diagnosis, not confirmatory diagnosis, just an adjuvant technique. You need to go for a conventional biopsy.
So which one is better, conventional biopsy or FNAC?
Conventional biopsy. That's a gold standard as of now.
So what is the best treatment modality in edentulous patients associated with OSMF?
First, grade it clinically. That decides your treatment plan. Habit cessation is the first thing. If it's an exclusive limitation of mouth opening with depapillation and a burning sensation, medically management with an antioxidant or an exercise or an intralesional injection of corticosteroids or a placental extract or a hynidase with physiotherapy. As a clinical tip, if the patient has got a depapillation with a pale atrophic mucosa, do a hematological examination for the patient, because if the blood picture is altered, an anemia or a low RBC, that can be a potentiating factor for a malignant. If there's anything, correct this one. Or intralesional steroids. You can give curcumin extract, has been quite effective. Pentoxifilin can be given, which helps in healing the fibrotic bands, and it also causes increase in vascularity or angiogenesis, which helps in healing of the lesion. So there are an n number of treatment options available to you.
Thank you, sir. The next one is, what is the guideline for treating varicose leukoplakia as recurrence is higher?
Varicose leukoplakia, the only guideline of treatment is surgical excision, wait and watch so that it doesn't recur, or if it's transformed into a established carcinoma, then you'll have to go for the conventional treatment options available for carcinoma. There is no, as far as my limited knowledge goes with the literature, I don't think there is any guidelines as such available for managing varicose leukoplakia.
Okay, sir. Thank you so much, sir. That was our last question.